Good afternoon. Happy Friday. Welcome to Instagram Live with Braca Strong today. And our special guest is Dr. Gomez, who will be speaking on cardio health. And we're so honored to have him as our community is changing and different. Knowing your options and what's available is so imperative when you have a diagnosis of cancer or you are a provider. Cardiac health plays a really big role in our community, and we are fortunate to have Dr. Gomez speak to us and prepare us and know our options and what's available. So again, thank you so much as we are just waiting for Dr. Gomez to tune in and join us in our live today. And today's Fact Friday. So when you talk about the facts, today we talk about the facts of cardio health. So stay tuned as Dr. Gomez is joining us, and we are honored to have him speaking today because cardiac health is so important. Again, cardiac health plays such an important role in our life, whether even on a cancer journey or not, right? You have hold on one second, I'm sorry. Hello, everybody. Thank you for tuning in as we are just waiting for Dr. Gomez to join us this morning. Again, please tune in and wait for just a couple minutes as our guest speaker is logging in. Kathy, it was great speaking to you last night, and I'm so happy that you reached out to me and we are able to provide the services that you need to women in our community. Hey, Dr. Gomez,
Hey,
welcome.
hi, how are you doing?
I'm good. How are you?
Great, thank you.
How does it feel to be on Instagram Live versus Zoom?
This is my first time. It's my first Instagram live that I'm done, so hopefully I won't mess it up.
Perfect. No, easy. Perfect. Thank you so much for joining us. So for those of you who just joined, we have Dr. Gomez speaking today on cardiac health. And what I'm going to do is allow Dr. Gomez just a couple minutes to introduce himself, and then we'll go ahead and get started with our program as cardio plays a really big role in our lives, as all of us know. But when you're faced or diagnosed with breast cancer, any kind of cancer, our heart is definitely impacted. So we specifically asked Dr. Gomez to come on and really talk about cardio and oncology.
Yes. Well, first of all, thank you so much, Tracy, for inviting me. This is an amazing organization that I'm very proud to have been a part of in previous occasions. And really, I cannot say enough great things about this community that you and your peers have created in terms of supporting women that have been affected by BRCA positive tumors, particularly breast cancer and ovarian cancer, as we know. The world of cardio-oncology is a relatively new world. It's a new subspecialty of cardiology, and it was born from the need of realizing that cancer patients are affected in multiple ways in terms of the cardiac well-being. The cancer can affect the heart in multiple ways. The cancer itself can produce changes in the heart muscle that could be deleterious to the health. As most of you know, cardiac treatments can also be toxic to your heart muscle, and that needs to be followed up and treated. And ultimately, patients with these cancers or cancer in general will have their own risk factors for heart disease. Doesn't mean that they're immune to heart disease because they survived the cancer. If they have risk factors, because the survivorship is a major part of this presentation, and we're going to talk about that later, there would be no point in surviving your cancer and then getting a heart attack. Okay, so all those things combined basically created this new subspecialty of cardio-oncology. When this came out, it was for me a bit of a match made in heaven, because before I decided to become a cardiologist, I wanted to be an oncologist. But I decided to do cardiology. I'm very happy I did that. But I always kept up to date in terms of cancer treatments, and my peers were always surprised how come I knew the chemotherapy. Well, because I liked them, and I really like to follow up on that. So when this opportunity came up do cardio-oncology, I just jumped on it immediately. The entire specialty, we can say, was more or less created at MD Anderson in Houston, where they really were the first ones to realize, no, we need a whole set of cardiologists just dedicated to this. If any of you has been in the MD or in the area of Houston, MD Anderson is just ginormous. Multiple buildings. We're very happy to have MCI, which is a beautiful facility, but you can multiply MCI times 6 easily, and that would be MD Anderson. MD Anderson is just enormous. And therefore, the volume of cardiac complications that they get is immense. So they needed a whole department within MD Anderson for cardiology and to treat these things and, of course, do research and see what we can do about this. So it was kind of created there, but it was then refined in multiple places. And basically, every major cancer program in the US and Europe and Canada will have a cardio-oncology department. And we're very proud to have joined forces with Miami Cardiac Cancer Institute, which is really, in my opinion, the premier cancer center in our area. And we are very happy to deal with many, many, many patients. Now, due to the nature of the disease and the nature of the chemotherapies, a big chunk, in fact, let me take that back. Not a big chunk, but the central core, the pivotal stone of any cardio-oncology program will be breast cancer, which is, of course, of crucial importance to this group. Therefore, we have seen multiple patients with breast cancer. It applies, of course, to all forms of cancers. Cardio-oncology is very important to breast cancer, but incredibly important to lymphomas, leukemias, colon cancer, many other forms of cancer, prostate, head and neck, you name it. Any form of cancer will have some kind of interaction with the heart function. But just because of the sheer volume and the fact that virtually every form of chemotherapy or every protocol of chemotherapy for breast cancer will include some form of toxicity to the heart, then breast cancer is by far and away the central core of any cardio-oncology program. So that's as a matter of introduction. I'm otherwise a cardiologist at Miami Cardiac and Vascular Institute. I'm from Panama, and I did my medical school in Panama, very proudly so. But then I moved to Canada for 6 years. I did 3 years of internal medicine and 3 years of cardiology at McGill University in Montreal, Canada. Montreal is a city that I absolutely love. If you haven't been there, I highly recommend it, but just go in the summer. And then I went to Boston, to Tufts Medical Center, to do my year of cardiac catheterization and angioplasty and stenting. I'm old enough to tell you that when I finished my training in cardiac catheterization, there were no stents. So the stents came in after I had finished my training. So I've seen the evolution of interventional cardiology from a very early time. That is one of the most important things that I do besides cardio-oncology for MCVI is to do cardiac catheterizations. And then, of course, I have a very large office practice. I'm what they call a nuclear cardiologist. So I deal with nuclear medicine exams for the heart. That was part of my training when I was at McGill. And nuclear cardiology is much less important nowadays, but it used to be incredibly important for the management of cancer patients. Because before we had the high definition echoes we have nowadays, the follow-up was all done with nuclear medicine testing in terms of the heart function. And we still have to use it in certain occasions. We can talk about that later. So that's the broad introduction of what I do, who I am, and why am I doing this.
Well, thank you so much for that. I learned more than I knew before, and where you went to school and all your background. And I really appreciate your time and dedication, as it's so important, as like you said, over the years, medicine has evolved, right? Like our community has changed. Like it wasn't what it was 20 years ago compared to now, especially I'd imagine in cardiology.
There is no comparison. I mean, the field has evolved amazingly well, to the point that, is very well reported that many cardiac conditions the treatments are so advanced nowadays that patients that for sure were going to die of heart disease, now they survive and then they die of something else. I mean, eventually the mortality will be there for all of us, but we have cut back on the mortality from heart disease tremendously.
So one question came through, and do you feel like multiple cancers can have an increased risk of cardiovascular disease versus having cancer once?
Well, the answer is absolutely yes, because with multiple cancers, you will be exposed to multiple chemotherapies. Particularly, just to give you an example, it's not that rare for patients to have a presentation where they had some form of lymphoma when they were very young, and then they would have, for instance, breast cancer when they're older. Well, guess what? Both cancers are treated with adriamycin. Adriamycin is the prototype of toxic chemotherapy, and that would create problems, because many times, there's only certain dose of adriamycin that you're supposed to get in your lifetime. And some patients basically exhaust that dose with the initial therapy, and then you get something new. It's hard to give it. It's not impossible. It's not that you cannot give it, but it requires extra testing, making absolutely sure the patient's heart is perfectly fine. But it creates multiple things. So yes, you're going to be exposed to chemotherapies multiple times. Yes. And besides that, like I mentioned, cancer itself has an effect on your health overall and in your heart function. It doesn't have to be the chemotherapy itself, but just the fact that you had cancer, particularly if it was the type of, if you're one of the lucky ones that had an early form of cancer, easily treatable, and you didn't really get such a hit on your body that badly, well, that may not be too bad. But if you had forms of cancer where really and you were exposed to multiple things, where you had to be in the hospital multiple times, your counts were low for weeks and weeks, that takes a toll on the body. That is like if you were in a car accident where you had to be in the hospital for weeks, that your body gets beat up. So yes, that multiple cancers will increase your cardiac risk. Having said that, of course, the treatments are so advanced nowadays that many patients survive the whole thing and without any major complications, and many patients survive with totally normal and healthy hearts after everything. But obviously, the more cancers you have and the more exposed you are to treatments and to the biology of cancer itself, the more close follow-up you need to have with a cardio-oncologist.
As we talk about cardio-oncology, and maybe we want to touch base on like chemo and cardio-oncology. Now, I know not everybody's lucky to have an MCI like us and have a division where we have, oncology, cardio-oncology, gyno, breast in one center. But like, do women see you before? Do women see you after treatment? When is the right time to have a cardio-oncologist involved in their treatment to make sure, obviously, that their survivorship, their cardiac doesn't impact their survivorship?
Well, that is a superb question, of course. It depends on the oncologist. The oncologist is the ones that is the person that always calls the shots. And not everybody needs a cardio-oncologist. If you're a healthy person, a young person with no risk factors, totally healthy, and you're going to be treated with low doses of chemotherapy or chemotherapies that don't usually affect the heart, you don't need to see a cardio-oncologist. Even if you're going to be treated with chemotherapies that affect the heart, if you are a totally healthy person, all that needs to be done is just to follow up the ultrasound. And the oncologists have been doing that for the last 30 years. So not everybody needs a cardio-oncologist. So who needs a cardio-oncologist? Well, like we mentioned, if this is your second bout of cancer, you probably should see a cardio-oncologist. If you are older, if you are 55 or older, 60, 65, etc., and you have risk factors, whether or not you have, just the fact that you're 65, that is already a risk factor to be seen by cardio-oncology. If you have other risk factors, if you have diabetes, if you have high blood pressure, If you are significantly overweight, all those are risk factors that should ring a bell to the oncologist. Say, okay, I want you to follow it with the cardio-oncologist. And that is the bulk of the patients that I see. So that's pretty much the short and long question, the answer to your question. Of course, it'll depend tremendously on the type of chemotherapy that the patients are going to have. Again, for breast cancer, for instance, if you have a HER2 negative tumor or a triple negative, you will get most likely adriamycin. Well, adriamycin, like I said, is a prototype of cardiotoxic treatment or chemotherapy because it has been used for a long time. Now, we still use it because it's immensely effective. And we want to keep on using it because it's amazing. It's a great medication. The percentage of cures is very high. So we use it not only for breast cancer, but it's used very commonly in lymphomas, leukemias, lung cancer, many other forms of cancer. And then, of course, if you have a HER2 positive tumor, okay, you will get Herceptin. And Herceptin is also known to be cardiotoxic. Maybe a bit less so than adriamycin, but also needs very close follow-up. In fact, with Herceptin, with trastuzumab, which is the generic name, very commonly patients will get long-term treatment with Herceptin. So they complete the initial protocols and then they stay on Herceptin up for a year's time, sometimes even longer. It depends if they still feel there's activity in the tumor. So these patients need to have constant follow-up with echocardiogram. That would be a typical patient that probably will require a cardio-oncologist. Okay. Now, as it pertains to this particular group, breast cancers tend to be more in the HER2 negative category. So the main one that you should be aware of is, of course, adriamycin, because that one is going to be used almost for sure if you have a HER2 negative tumor which is invasive. If you have a HER2 negative tumor and is ER positive and is localized, you don't need chemotherapy, or many patients will not need chemotherapy. Just a lumpectomy with radiation and hormonal treatment will be enough. But if it's an invasive tumor or locally invasive, or is evidence of distant metastases or lymph node involvement, you will need heavier chemotherapy that will include most likely adriamycin.
So there's a question. Please give us your thoughts on GSL changes in relation to adriamycin. At what % decrease should I be concerned?
Sorry, what was the question? I didn't
So
understand.
it's please give us your thoughts on GSL changes in relation to adriamycin. At what % decreases should I be concerned?
Yeah, the answer to the question should be GLS. GLS. So when we follow up cancer patients in terms of their heart function, for years, the mainstay of therapy has been the follow-up of the pumping function of the heart, okay? And that we call that the ejection fraction. Now, you need to realize that the ejection fraction, the follow-up of ejection fraction has been done for years. Like I mentioned at the beginning, before the echoes were really this good, 25 years ago, echoes were much crummier than what they are now. But in the old days, we used to follow this with a radionuclide ventriculogram, a nuclear medicine test that we inject. We get the red cells of the patient. We actually tag them with a radioactive material, technetium for those who know their chemistry. And then we re-inject it to the patient. It's their own blood, so it's no issues. But that goes into the heart, and we can see actually the image of the heart pumping. Now, here you need to realize that there is no heart that pumps 100%. Okay, whenever your heart pumps, there's always something left inside. And the pumping function of the heart, the normal, would be anywhere between 55-65%. There's patients that have a much higher ejection fraction, but a minimum of 55%. That's what you really want to have for any of these treatments. So that is the number we're going to follow. And when we start seeing that the ejection fraction starts dropping, then we need to treat patients if they have blood pressure problems. We need to try to reverse that any way we can. Sometimes we need to suspend the therapy. We need to just tell an oncologist, listen, give me a month to take care of this, and we put the medications, patient on medications, very quickly, and we do a quick follow-up, and then we return them back for more chemotherapy. Keep in mind that as a cardio-oncologist, my main mission is for the patient to go back and get their chemotherapy anyways, which is what, at the end, what really is going to save them. But it needs to be done in a way that is safe. You don't want to give chemotherapy to the point where you're going to be a heart cripple, and then what was the point? So that's why we need to act on this very quickly. Now, the GLS that the other member was referring to is our latest tool in the follow-up of oncology patients, and has really changed the landscape. Global longitudinal strain refers to the fact that when the heart beats, it basically twists and turns upon itself. The heart just doesn't beat like this. It just goes like this, okay? It's like if you're squeezing a wet towel, it squeezes like that. And that's how the heart really pumps. It twists and turns. And the newer echo machines are such high definition that they can see points within the heart muscle contracting at different parts of the heart, okay? And we can assign how much that contractility really is. And that, it gives us an average number. This is all a computerized assessment, but the technician and the oncologist need to make sure that the limits are well traced so the computer can have a good readout. And basically, the computer will give you the number of global longitudinal strain. By that meaning, how much effort is your heart making in reaching to that ejection fraction that we just talked about. Well, there's many studies, originally actually from MD Anderson, like I mentioned, but probably perfected, if you want, at Sloan Kettering, which is our sister hospital at MCI, that show that GLS, or global longitudinal strain, is an early warning system. You can have changes in your GLS before the ejection fraction goes down, which is fantastic for us to follow, which means that whenever we see a GLS going in the wrong direction, then we can institute other measures before the ejection fraction actually suffers. So it's a tremendous tool, and thank God we have very modern machines at the hospital and in our diagnostic center at MCBI Cardiology, where we can do GLS basically in all the patients. Now, there will be patients where you cannot do GLS because multiple reasons, because maybe they're a bit overweight, or they've had recent surgery and you can't really press with the probe too hard because obviously it would be painful, or sometimes there are implants in between, prosthesis. But in the vast majority, we can measure that. Now, the normal number, to address the specific question of the member, is a negative number. Okay, so it's minus 17% as GLS. So normal would be minus 17, or anything more minus than that. Okay, minus 20, minus 22, that would be normal. A very strong heart, very active heart, you have a GLS of like minus 22, minus 23. That would be the numbers that we follow. Now, if that number starts going up, that meaning less negative, so now it's minus 15, minus 13. Yes, we don't need to stop therapy. If the ejection fraction remains normal, we don't need to stop therapy, but we have to tell the oncologist, listen, we need to put this medication, this patient on medication, to make sure the blood pressure is on the low side. We need to tell the patient to start exercising a bit more. Sometimes you need to decrease the dose to make sure we're not going to run into trouble. So it's fantastic to have this early warning system before the heart is actually affected. It's particularly useful for Herceptin, for HER2 positive tumors, but it definitely works with adriamycin, and it works for multiple other chemotherapies that are toxic to the heart.
Does radiation and tamoxifen affect the heart?
Well, the radiation itself, yes. And tamoxifen also. Well, tamoxifen, we just talked about it. no, sorry, I was talking about trastuzumab or Herceptin. Tamoxifen itself, well, tamoxifen being a hormonal blocker, not really considered chemotherapy, but it will retain fluid. Like any hormonal manipulation, particularly in women, they always win when it comes to retaining fluid. It can retain fluid, and therefore it can worsen hypertension. It's rare that it will produce hypertension, but in patients that are hypertensive already, it can get worse because of long-term treatment with tamoxifen or anastrozole or any of the newer ones. They all will have the same effect. Now, radiation therapy is a whole different thing, okay? And here we need to divide patients in two broad categories. The ones that get radiation in the left breast and everybody else, that would be one of the categories. And then patients that got radiation many years ago, like over 20 years ago, or modern radiation. That would be the other broad category. Obviously, radiation in the left breast, especially if it was done many years ago when radiation was less precise, it is concerning because it has been shown not only in cancer patients, but also lymphoma patients where you get a lot of radiation right in the center of the chest, that it can accelerate atherosclerosis, by that meaning coronary blockages. And in extreme cases, it can accelerate valve problems. The aortic valve can actually block off because of excessive radiation, as the aortic valve is in the front of the heart. It gets the brunt of the radiation right there. So yes, radiation can have a problem. But if you have radiation in your right breast, obviously then the heart is not included there. And modern radiation is much more precise. So modern radiation is rare that it will affect the heart itself because it has a more precise beam. And especially if you have MCI, we're amazingly lucky to have a proton therapy machine, which is like a laser beam directed just to the tumor. Almost nothing else gets affected. So that will produce no heart problems. And basically, proton therapy doesn't affect any other organs. It really just targets the tumor, which is an amazing thing that we have in MCI. And if I think it's the only proton therapy in the southeastern United States. It's amazing to have it.
So one of our ovarian cancer survivors asked, what about the effects of cisplatin and Paxitol on the cardio side?
Yeah, well, ovarian cancer is obviously a whole different thing. It would be rare, so to use adriamycin, and you will never use Herceptin for ovarian cancer. Like the member mentioned, cisplatin is one of the mainstays of therapy. Paclitaxel, Taxol would be the other mainstay of therapy. They have many other different chemotherapies. Those two rarely affect the heart muscle. So we don't have to, there will always be an initial echo just to make sure the heart is okay for just the trauma of the chemotherapy, but it doesn't really affect directly in terms of cardiotoxicity. Having said that, treatment of ovarian cancer is a bit more involved, and it's a bit more traumatic to the system, if you want. And therefore, when we see cardiac complications, they tend to be mostly in the overall condition of the patient, in terms of, generalized weakness, infections, the extra trauma that the heart is exposed with the treatment of ovarian cancer, which in many cases, thank God, it's not that bad, but in many cases, it can be very intense. And that is how you really get affected mostly with ovarian cancer. Now, when I see a question there for intraperitoneal treatment versus IV. Well, in all fairness, probably it's not a major difference. Again, the main thing would be the effect of the overall treatment in the cancer condition. If you get intraperitoneal treatment, you're talking about, peritoneal spread of the tumor. So obviously you'll probably be a bit of a sicker patient in that condition. But having said that, no, they respond very well. and many patients escape unharmed. And like I said, those treatments per se don't tend to affect the heart that much, but the overall condition, yes. And ovarian cancer tends to be more of an older population that breast cancer. So ovarian cancer patients tend to have other conditions.
She's BRCA too. She's BRCA positive as well.
Yeah, well, no. Obviously, there's all the things that need to be monitored and concerned. But from the heart point of view, an older patient, which would be a bit more typical for the ovarian cancer population, you need to worry about the diabetes, the high blood pressure, cholesterol, etc. So there's many other things that need to be done.
A follow-up question. So can you actually improve the GLS with exercise once damage has been done?
Yeah. So that is a great question because it opens the door to multiple topics. Probably the most important topic of that question is the premier importance of physical activity in the prevention and treatment of cardiac conditions related to cancer, particularly with chemotherapy. They always ask me, doctor, what can we do to prevent this? Well, there's no magic bullets. There's no medication that you take this and it's going to protect you. Actually, there are medications that are used in children, because adriamycin is used commonly in the acute leukemia and that is the most common in children, which is acute lymphoblastic leukemia or ALL. Adriamycin is a big part of the treatment, and there are medications that are given to children to prevent toxicity. But for whatever the reason, nobody can understand why, it doesn't work in adults. So we don't use it at all. It doesn't work in adults at all. Now, there are many studies that are being done in terms of prevention with medications that we already use to treat weakened hearts. Okay. The type of medications that we call beta blockers, for instance, metoprolol, carvedilol, is being used to try to prevent this. One medication that is showing a lot of promise, but the final results of the studies are not out there yet, is called Entresto. You've probably seen it on TV. They have many ads. Sadly, the ads are a bit on the ridiculous side because they have people singing tomorrow, which I don't know that's really a favor to the medication. But I will have to say that Entresto is really one of the most amazing advances that we've had in cardiology and in medicine in general in the last 25 years, because it really acts for patients with weakened hearts. It will help it, A, to get stronger, B, to decrease mortality, and C, to decrease hospitalizations for heart failure. And one of those side effects, or one of those effects that they're hard to characterize or to give it a number, for instance, is just the overall well-being. Patients love being on Entresto. And they will tell you, doc, you can change any other medication, but don't take me off this one because I just feel so much better. So Entresto is being used actively for the prevention of cardiotoxicity. But the one thing that I tell each and every patient that works very well to prevent toxicity is exercise. It's been shown multiple times that exercise helps prevent toxicity from chemotherapy. As you can imagine, at MD Anderson, they're close to the Houston facilities of NASA, where the astronauts train. So they did actually many studies there with the NASA exercise physiology team. And they concluded that definitely exercise prevents toxicity, to the point that one of the things that is being really advocated by the cardio-oncology groups and nationally is for the insurance plans and Medicare to pay for cardiac rehabilitation before and during chemotherapy, as it has been shown to prevent toxicity. Now, you don't necessarily need to do it in a gym or under conditions of cardiac rehabilitation. Just your regular walks around your neighborhood will do. But it's important to do it, and it's important to keep reminding yourself that it's important, because many patients, as you can probably all imagine, the last thing you want to think about is exercise when you get chemotherapy. You want to go home and just stay in your sofa for the entire day. And that I always tell the patients, listen, the day off and the day after, I'll give you a break, okay? But from then on, you need to make the effort to exercise. Now, going back to the question, so that was in terms of exercise and what it can do for you with cancer. Now, the reversibility, it's definitely possible, no question. Most likely reversible with Herceptin. When it's a HER2 positive tumor, the reversibility is almost 100%. It's very high numbers. If you just hold it for a little while, it just goes back to normal. And you can re-challenge. You can wait for a little while, put the patient on medication, tell them to exercise. You show that it's back to normal, and they can go back on Herceptin. And usually nothing happens. So that's a nice thing about Herceptin. So yeah, you can recover 100%. With Adriamycin, for instance, you can also recover 100%. No question about that. But there will be a percentage, and that percentage, thank God, because of all the cardio-oncology programs and the cooperation with oncology, that percentage is smaller and smaller and smaller, where the toxicity will be permanent. And I've had patients that have, are left with weakened hearts permanently because of the use of Adriamycin. So there it can be permanent, but thank God it's a minority of patients that really. It used to be said that the overall toxicity for Adriamycin for all comers, the old numbers was 5%, but that number is much lower nowadays because we know that the therapies and the exercise and just the awareness of it have decreased it. So I would rate it really in 2021 more in the 2 to 3% of toxicity. Now, out of that group, that 2 to 3%, again, it used to be said that a quarter would have permanent damage. This is a quarter of 2 to 3%. Now, keep that in mind. But I think that number is much less now because most of the patients that we see with Adriamycin toxicity with the right medications, virtually all, they go back to normal and to live normal, healthy lives otherwise afterwards. So the answer, again, is exercise is crucial. Yes, changes can be reversible in the immense majority of the patients. Not only can be reversible, but exercise will prevent them. So I cannot emphasize the importance of exercise more than that.
So we have one more question and then we're going to close out. What do you feel the likelihood of kidney failure is with heart disease due to cancer issues?
Well, kidney doctors say that they worry about the heart because it pumps blood to the kidneys. That's the only thing they worry about. They say it seriously and jokingly at the same time. So yes, you would only have kidney issues if your heart is weakened in a tremendous way. And then you could have kidney issues. But most of the time, if you develop toxicity, because we're doing these echoes so frequently, you catch it really on time, and it's rare that it becomes really that bad. So with a mild toxicity of the heart, it will be very rare that you'll develop a kidney problem. And if you develop a kidney problem, most likely it will be due to the other chemotherapies, but not to the heart itself. For those that asked for ovarian, cisplatin, could produce kidney issues in a minority of the patients. There's many other cancer treatments, which is why when you get the chemotherapy, you get such a flush of fluid to make sure that the kidneys are well flushed and they're not going to retain the chemotherapy. So again, kidney issues due to heart disease only occur with very severe heart disease, and those happen very infrequently, thank God, because we are really on top of it.
Well, thank you so much, Dr. Gomez, for coming on and answering all these amazing questions that ladies have sent in, and just being able to provide feedback to women and share really what cardio-oncology is. And we definitely always look forward to having you back on in the future, because this is a topic that really isn't spoken about as it's just evolving. So we here at BRCA Strong always want to continue to make a difference and educate the community, to know your options, to be your own advocate. And really, ladies, if you're not seeing a cardio-oncologist and you learned anything and there's not one available in your institute, look what's around you. If you're having any complications and you can't find one and you want to come to Florida and see Dr. Gomez, or you live in Florida, you can feel free to always reach out to myself, Kate, or Tammy, as we have partnered with a private jet company that will be helping women, taking them from different states to institutions like MCI to be able to provide the standard of care top, as it's so important to make sure that we make a difference and women and men live longer who were diagnosed, unfortunately, with cancer. And just making the change in our community is so imperative. So if there's anything I can do, continue to help educate, I'd be here for you at any time. You can feel free to reach out to me.
Well, Tracy, the very last thing I would like to spend a minute just telling the entire audience that we can never forget the final message that with or without chemotherapy, but even more so if you're inflicted with cancer and you are getting chemotherapy, you must take care of your heart. By that meaning, if by any chance you're a smoker, you have to quit. There's no ifs, ands, or buts. You must quit if you smoke and you get chemotherapy and you have cancer. And obviously, if you have other risk factors, if you have high blood pressure, if you have diabetes, if you know your cholesterol is high, if you know you're terribly overweight, a little chubby maybe, but if you're really overweight where it's a problem for you, you need to take care of those things because they're going to have an impact in your heart one way or another. So don't forget the basics. The treatment of cancer is such a sophisticated thing, but always go back to the basics and keep your exercise up. Try to eat a healthy, type of diet. You don't have to go crazy with your diet, but try to eat healthy in a way that you're not going to gain weight. Make sure you don't smoke. Make sure that you take your medications for the other risk factors we talked about. That is of immense importance for sure.
And we definitely have to have you back on, as two women have sent over on the impact forced menopause on the heart. How is the heart affected when you're pushed into menopause or you're not on hormonal therapy?
Effects, no question. Yeah.
So we'll definitely set up another time to have you back on, because I'm super interested in hearing about, forced menopause and the impacts on the heart, like heart disease in your family. For example, as we're wrapping up, my dad died of a massive heart attack. I'm BRCA2. I'm not on hormonal therapy. I had a full hysterectomy. Do I need to see a cardiologist? Do I need to see a cardio-oncologist? These are all things that really, again, aren't spoken about in our community. And really, that's why we're so grateful for physicians like you to come on to educate, because women are now sending a million questions, menopause and the heart. And I know from what I've read and, even learned from you over the several times, is it is impacting our hearts, right? Because if we don't have hormone treatment, cardiac issues start to play. And I remember, I can tell you back in 2004, somebody said to me, when you have a hysterectomy, you have to have cardiac follow-up. Well, here I am from 2004 to 2021. I've never seen a cardio-oncologist turn on, a cardiac. And those are all topics that, again, really need to be spoken about and addressed.
Yeah, no, absolutely. These are very important. It is known, that especially when you're an older patient, you die more often of heart disease than your cancer. For cancer patients overall.
Wow.
Okay. Once you go past the 60, 65 age group, if you had cancer, you are more likely to die of heart disease than the cancer. So the curves cross over at the 65 years. And both curves, obviously, mortality is just a continuum throughout our lives. Okay, but the curves for heart disease and cancer are kind of parallel, but at older ages, they cross over. So then you die more often of heart disease than breast cancer. And in fact, one of the things that I'm very proud to be a member of is Women Heart. And I encourage you all to log into womenheart.org.
Okay.
It's the National Organization for Women and Heart Disease. Baptist and MCBI here in Miami have the only local chapter in the Miami-Dade area. And up until recently, we had the only Spanish chapter in the U.S.
Amazing.
And I'm the physician champion for Women Heart. And the message there always has been that for as much as we like to support 300% anything that can be done to prevent cancer and to treat cancer and to research cancer, and breast cancer is such a common thing, such a dear thing to women, of course, in general. The number one mortality for women is heart disease, by far and away. So obviously, if you have risk factors, if you have a very strong family history, and you survive cancer, don't forget about your heart.
Thank you so much. Remember, don't forget about your heart, ladies. We need them.
Okay.
Thank
Absolutely.
you so much, Dr. Gomez. It was great seeing you, and look forward to having you back on.
I want to congratulate Wicked Astrowolf, who has participated tremendously in the conversation.
She's a 6-time cancer survivor, and she carries the BRCA and the CD1 genetic mutation. So
Yeah.
she's very active in a lot of our Instagram lives to try to get more answers and kind of, drive herself in the right direction. Kamali also, they're both, I mean, we have an amazing following and women that are really interested. And I think, again, as this is the second or third time we've had you on, I think maybe having you on a little bit more to really educate and prepare women, because again, we need our hearts, right? And even on the preventative side, as we talk about preventative care and women who have genetic mutations of hysterectomies who don't, who go into early menopause, how does that affect the heart, So we definitely look forward to having you back on.
All right, Tracy, anytime, just give me time and then we can do it, okay?
Perfect.
All right.
Thank you, Dr. Gomez. Have a great day.
Bye-bye.
Bye-bye.